It's my great honor to introduce the first speaker of today's workshop, Dr. Akira Ndiape. But she told me just call her Dr. Akira. It's more easy. And Dr. Akira has a very, unique experience because she got her training in anesthesiology from Dr. MGR Medical University in India. And after a couple of years of clinical practice, then she decided to, but I didn't ask her for why. She went to Singapore and then got the master's degree in public health from National University of Singapore. So after that, she joined the Health Promotion Board, and today she is the Deputy Director of the Cancer Screening and Management. So in the past 15 years, she had a lot of experience in the screening of various kinds of cancer, and today she will focus on colorectal cancer screening. And I just give you one important finding recently is now in today's Taiwanese adults, the most common cancer found among males is colorectal cancer. Because we already have decreased smoking rate, we have prevention vaccination for the liver cancer. So now colorectal cancer is the most common. More important, patients are getting younger. So the main is that if we can find earlier, then we can save a lot of lives. So today we have a very important opportunity to learn from Dr. Akira from her experience in Singapore. Now let's welcome Dr. Akira.
Good afternoon, everyone. Thank you very much for the kind introduction, and also for Taiwan and Taipei's very well-known warm welcome since morning. I'm so stuffed with food. I don't know about you. I hope my talk later doesn't put you into a food coma. And I'm thankful I'm the first speaker, so I can go back and relax to this. So firstly, it's my honor and privilege to be here at this EPEC conference workshop on the NCD, and it's a very pertinent topic today on colorectal cancer screening. And I'm also very privileged to share Singapore's strategy and our approach to colorectal cancer screening. We go a long way as far as our screening programs are concerned. We started our signature program for breast cancer screening in early 2000, so it's more than a couple of decades since we started our programs, and we've built up on many of our programs since then. For those of you who are not familiar with Singapore, we are also a very small island nation. We call ourselves the Red Dot. And pretty much you can cover east to west of Singapore probably within an hour or so. It's that small a nation. But of course, there's a lot which is punched and packed as far as the nation is concerned. And but I'm very happy and I'm honored to be sharing about our experience for this particular program. So in today's outline, I'll just cover basically the introduction of how we are organized in Singapore, in particular the Ministry of Health. And I come from the Health Promotion Board, how is the structure, and then what the National Screening Program is like in Singapore. And then very briefly touch upon the cancer landscape as well as certain areas of cancer screening in particular. Then I'll go forward to share about our program, the operations and clinical governance framework, as well as a key area on education awareness, which is pretty critical to Health Promotion Board. Lastly, a very brief on how the program is performed, which is something I think many of the previous distinguished guests also were talking about. Is it really cost effective or clinically effective? And if so, where and how do we progress? Of course, all of this is not without challenges, so I'll share a bit about Singapore's challenge in running the program and what the future is like. So a very brief about what and how we are organized. It's pretty similar to what many countries have, including what Taiwan has. We do have the Ministry of Health, which is the main, which is under the government structure, and we have 3 statutory boards. Health Promotion Board is the board. We are actually for the vision of Nation of Healthy People. We actually look at the health promotion and disease prevention efforts in Singapore. So we are a national agency. We're also under the government. It's just that we are an autonomous board. We do have the board of directors who we actually report to for all of our work plans, our KPIs, etc. But we also directly report back to the ministry. And for those of us, we had a chat earlier. We are not the ATM. The ATM is actually here. The Ministry of Health is also our funder, so there's a lot of supportable KPIs there. We do have sister concerns like the Health Science Authority, which is the equivalent of the FDA, and the Communicable Disease Agency, which is the newborn child, as far as we're concerned, which is the equivalent of the communicable disease side of the house for us. So in the screening landscape, very quickly, who are the stakeholders in charge? While it looks like at a very large level, it's a Singapore government effort. We cannot do this alone, so we do need very many players in the whole landscape. To start off with, of course, we have our funder and policy owner, which is the screening policy owner with the Ministry of Health. We, Health Promotion Board, are the program owner, the National Screening Program owner, as well as the implementer. We do have the full oversight of the program, right from end-to-end services is what we call. We do work with the health clusters because a lot of the work which is done by HPB, we have a very small team in health promotion work. We cannot do the work ourselves. So most of our services are actually outsourced to our providers, and these providers are the healthcare clusters, as we call them, basically the hospitals, the polyclinics, the private and the public sector, as well as the laboratories and a few other parties who are involved. And last but not least, we also work with a lot of our NGOs, non-government partners. One key among them is the Singapore Cancer Society, who play a very major role in our cancer screening efforts, in particular for colorectal cancer. So what is the role of Health Promotion Board in the screening landscape? We actually support the Ministry of Health's role in the reduction of morbidity and mortality in the long term. And our role is particularly to look at early detection and management by encouraging people to go for screening regularly and for timely management. So we have 2 key roles here. One is we're not just the program owner and implementer, but we also have a role in the national education and promotion efforts. This is we do have an act called the Health Promotion Act. Under the statute, we are asked to, and we will be looking at the education efforts, and this also extends all the way into the screening program as well. The national screening program in Singapore is called the Screen for Life. Just until last month, we just had rebranded under a newer name called the Healthy HG Screening, about which I'll talk in tomorrow's session. But for today's session, the program is still under the context of Screen for Life. And this is a program where we cover not just screening for colorectal cancer, breast and cervical, but also for chronic diseases, which are metabolic diseases like diabetes, hypertension, and dyslipidemia. So in a nutshell, you can see we don't just look at one program. It is pretty much a composite of a few different programs put together. A bit of history into how we started the program. So the original program, which is the breast cancer screening program, we started off as the Breast Screen Singapore. We took a lot of learnings from Australia. It was under that umbrella, and then this was sometime in 2000 to 2002 when we started the program. We started with screening mammograms. And in 2004, we added on the cervical cancer screening program. And then in 2007, we brought in the cardiovascular screening. I think I was sharing earlier, Singapore, we have a high risk, and one of the higher rates of morbidity mortality can be attributed to cardiovascular risk, which is cardiovascular diseases. So as an upstream promotion effort and prevention effort, we then brought in the screening for cardiovascular risk, which is screening for diabetes, hypertension, hyperlipidemia, and obesity. So this part of the program was then added on to cardiovascular. And of course, the last, which was added to this, was the colorectal cancer screening. In 2011, we introduced this under the national program. So when we started this whole program, each of these programs had its own individual programs, and we took a very disease-based approach, or a disease-centric approach. So we went by individual diseases. We used to screen separately. We used to do awareness. We used to do health promotion efforts in between. In 2013, then we realized we had to change. There was a lot of shift in how we were operating. And one of the key shifts was to move from a disease-centric effort, the screening, towards a person-centric effort. And that's how the whole program of Screen for Life, all the 4 programs were then brought under one common umbrella called the Screen for Life, and under which it was a very customer-focused or a client-focused angle. And the messaging, everything was kind of put under one common umbrella so that it becomes easier for the clients to understand and to also access services. So moving on to the colorectal cancer and screening landscape in Singapore. That's in a nutshell of how it looked like. When we started the program in 2010, 2011, colorectal cancer was still the largest, the highest, or the top cancer in Singapore, both among men and women. At some point, of course, breast was still the top, but somewhere along the way in the past 10 to 12 decades, it was kind of top 1 to 2. And then in the recent Singapore Cancer Registry report, colorectal cancer has fallen to number 2 position in Singapore for both men and women. But as far as the age standardized rates are concerned, you can see here for both men and women, there has been a rise. Singaporean population, we do have a high risk profile, and you can see the ASIR is actually, it has been increasing over the past half century or so. But the good news is at least it's beginning to see a stable plateau there, both in men and women, with possibly a slight dip as well. So that's something which is what we have to look at. As far as mortality is concerned, again, the good news is that we are beginning to see the decline, of course, with the introduction of the program, as well as other efforts besides the program. We have managed to bring down the mortality, and we hope we can bring it down to closer to the bottom line. And correspondingly, we have seen a good increase in our relative survival rates. It's good to see the green line going upwards and further above. And this is not just because of efforts of the government or the health sector. There's a lot of efforts as one nation to come into increasing this, because Singapore's country where we prided ourselves a lot on technological advancements, and a lot of advancements in the past couple of decades have been predominantly on tertiary care and quaternary care. So it's not surprising that our relative survival rates have been increased, because that's something which the hospital folks, our clinicians, do very well. So, having said that, we also looked at comparisons with our Asian counterparts, and as you can see, Singapore's incidence and mortality rates are kind of in line with other equivalent higher income countries. Then moving on to screening trends, this is something which has been like a bear bug for us for the past, I don't know how many years, possibly past couple of decades has been an issue. You can see here, this is around the time when we actually introduced the national program. It has seen a good increase in the screening rates, but over the past decade or so, it again has plateaued. And this is not the case just for colorectal cancer screening. We do have a challenge with other cancer screenings as well, both for breast and cervical. We've also seen a continuous plateau, and this is a challenge. This is an area which we think we need to work right upon. Just to clarify, just to be clear, the rates you're seeing here are from a survey result, which comprises both the program-based efforts as well as non-program. So in Singapore, there is no, we do not monopolize screening, i.e. Residents can access any of the screening services. They don't need to come to our national program alone. They can go to any of the private providers outside the program and to get access. So what we're seeing here is, in consolidation, the total population level screening rates. This does not represent the program level rates. We also compared ourselves with the OECD, and you can see there, we are far below the OECD average, and there's a lot we need to do in this entire space of screening trends. We did a deep dive to see how does it perform between males and females, as you can see here. The females are faring, participation in the program is much, not program, participation in colorectal cancer screening is much lesser compared to the males. Interestingly, in Singapore, we also noticed that possibly because it's a timeline effect, we're not sure. The breast and the breast and the cervical cancer programs were introduced almost one decade prior to the colorectal cancer screening program. And so the participation, if you see, or when we talk to women, they have a lot more awareness about breast and cervical. For some reason, they are not bought into colorectal. It doesn't just come to them. And we jokingly also say internally to say, as far as the guys are concerned, when they turn 50, they have only one item to screen for, it's only colorectal. Whereas for women, they have to go for three kinds of screenings, which is breast, cervical, and colorectal. They have to remember the frequency, they have to remember to go back every single time, and they have to do different types of tests across the whole thing. We also did a deep dive into looking at what we call as ethnicity in Singapore, but it could also be areas like what we call as the racial distribution. In Singapore, we have three major races or ethnicities. We have the Chinese, comprising almost about 70 to 72% of our population are Chinese. Malays about 10 to 12%, and Indians about 5 to 6%. We also see the spread across the three ethnicities, and you can see the ethnic minority population, they are fairly a little worse off compared to the Chinese majority. And in particular, if you look at the green graphs, these are the Malays. We do have a concern about our ethnic Malays, where the rates are at least half or even less than half of the Chinese majority, or even if I take the national average, they're much lower. So this is an area of focus for us, a challenge which we need to see how we get to. There's one more area which I couldn't get the slide, sorry, my apologies, I couldn't put it into this particular place. We also did a deep dive into looking at spread by income status. And in the income status, similar to most other countries which they have, our low income population, the rates of participation is less than half. So two main areas of concern for us would be, one is the ethnic Malays, and the second would be the lower income. So I'll move on to the national program. I usually call the program principles under three key headers, the three A's. We talk about appropriateness, affordability, and accessibility. In terms of appropriateness, what we call here is the screening test review committee. In the past, we used to have a lot of clinical practice guidelines, as what we call it. So individual cancer screening programs, individual cancer screening or individual disease-based screening used to have volumes of clinical practice guidelines being put up. In 2011, the Ministry of Health then formed this committee called the Screening Test Review Committee, which brought all the screening committees together. So this comprises of many representatives from Ministry, from Health Promotion Board, from academia, and the different colleges. For example, College of Radiology, College of Pathology, College of ONG, College of Ophthalmology, all are put together, and everyone will review the literature, come up with recommendations on what the guidelines should be for our population. It's very specific to the Singapore population. So we look at international literature, and we also look at the local literature, and then the guidelines and then the. So for a policy basis, Ministry of Health and HPB, we take guidance from this STRC's recommendation. So this falls under three categories, Cat 1, 2, and 3. Category 1, what we call, is suitable for population level screening, which means there is robust clinical evidence to say that you can actually go ahead and offer this for the population. Earlier, there were some comments about whether some of these programs or screening is actually cost effective. We don't just look at clinical effectiveness, we also look at cost effectiveness. In Singapore, we're very particular about the budget and the money being thrown in, and investment should be worth it. And so, is it? Oops, okay. I haven't even covered my program, so. I just need, okay, then I'll just run through quickly. Sorry. So whatever's suitable at the population level is where we then throw in for our national program. And the audience, as you can see, is 50 years and above. And the modality, we look at fetal immunochemical testing, as well as colonoscopy. For the national program, we have adopted the FIT test, which is, for us, we do a 2-day sample. And we also look at evidence to see what is the threshold, what is the FIT positivity rate, sensitivity, specificity, PP, NPV, and then we apply it in our program. Colonoscopy is actually not included in our program because, again, we have to look at the considerations because colonoscopy is actually a day surgery procedure. And so that cannot be applied into this. There's also the cost effectiveness which we need to look at. And so that is offered in a separate setting. So under the affordable screening, there's a lot of, we have this healthcare financing framework, which we famously call as the S+3F, which is subsidies and Medisave, Medishield, Medifund. This is the different tiers of safety nets we have in Singapore for the healthcare financing fees. So there's a lot of subsidy which is available, and all our residents can actually obtain the screening and follow-up at a very heavily subsidized rate. And under the new initiative called Healthy SG, we're now offering the screening and follow-up up to the point of primary care. It's now free. Accessible screening, we do have the program being offered at both the private and the public primary care setting. For us, screening is always placed in the primary care setting. The follow-up, which is the quaternary and the tertiary care, will then come into the tertiary setting. So we have close to 1,400 GP clinics, 26 polyclinics, and then 7 assessment centers. The assessment centers are our PHIs or the hospitals who take charge of the FIT positive cases, where they go for specialist care and then colonoscopy and treatment and cancer care. So I won't go to the details. I think this most of you will know. We cover the end-to-end kind of areas for this. We start with the components of the program from public education, the screen call recall mechanism where we do screen invitation. We do look at accessible and affordable services. And a major area which we focus on is standards as well as QA, which is quality assurance, in which the continued education is also for the clinicians and those who are participating in our program is pretty big. One backbone for us, which we call, is the IT system. It's very, very important and crucial for running the program and also connecting with many dots within the whole setting. And this 14 years on, since we started the program, it still is pretty important and we continue with a lot of things as we go. I won't go into the details of what our workflow is. Basically, the client comes to pick up the kits, returns the kit, the lab will process the results, and then the data is then sent into the screening system. And from there, they actually go into the data is also automatically pumped into the via the screening system. There's a program coordinator at our hospitals who will call the client to make an appointment for the SOCs. SOCs are our specialist outpatient clinic. And from there, they will get an appointment for colonoscopy. And from there, after the scope is completed, they will have either of the results. It's either polyps or colorectal cancer that the care goes through. If not, if they're normal, then they will do under care. But we do have a big challenge of between the SOC appointment and scope, you can see that there's a huge loss to follow up. So if they decline to do a follow-up, then they can cost. So in clinical governance, we do have independent committees, which we form at the government level. Health Promotion Board, we actually appoint these committees where we bring in the experts like gastroenterologists, pathologists, radiologists, etc., depending on which cancer we're talking about. And we have these advisory committees. And these committee, the members will then draw this policy and procedure manual, which is like the Bible for us to run the program. We also have equivalent QA manual and guidelines, which will help us to also look at the standards which we need to the program. We have a very robust audit framework where we do biennial or triennial audits of our centers as well as laboratories, and we also look at the manpower who are looking into it, like healthcare professionals. Last but not the least, also a continued training program, which happens within the hospital setting. We do have the QA indicators to see how we are performing. So these are very general, like scope completion rate, scope withdrawal time, perforation rates, bowel prep rate. These are all something which we look at. We set standards for ourselves. During the audit, we also look at how we perform. So from education, just a bit I would like to touch because it's something which HPB does quite a big area. There's quite a lot of the knowledge. We looked at the knowledge, it's about more than 90% of the clients and residents know about screening and know what to do. But it never translates to action because you can see only 4 in 10 actually adopted it. So we went into looking at what was the issue and why are these people not screening. We do a lot of insights, we do surveys to find out what the population challenges are. One interesting thing which came up was they found that screening was a lose-lose proposition. Why should I go through stress? We can understand if they went through a screening, they have a positive rate, which positive test result, which means they have an abnormal result. It's stressful, of course, right? You have a cancer and that's stressful. But if I go for screening and have a negative test result, they also said that it's stressful because they felt that they lost their time, they lost their money or effort put in. So for them, they felt either way I lose, so it's a double loss situation, I don't want to go to screening. Then we also had people or residents telling us that they had some negative experience or poor experience when they're screening. Many of them prefer to be in their blissful bubble because of fear or finding out about their illness, and because it's a cancer, they have more of this fear. So they want to stay in their bubble and not know about it. And last but not the least, which is very, very commonly found everywhere, most say that I feel fine, I don't want to get screened, and I think I'm healthy. And this is usually the younger cohorts who say I'm invulnerable, I won't get the disease, I won't get the cancer, so no problem. Don't touch me, don't come to me for screening. We also did an updated study a couple of years back. We found pretty much similar kind of results, except this time there was actually an additional part which they spoke about with the cost of screening. In the cost of screening, they're speaking more about the fear related to the burden of the disease, as well as burden of the follow-up care and cancer treatment, which is going to be a lifelong burden. An interesting thing which came up was also the fatalistic attitude. This was more specific to our Malay population. In our Malay population, they are very specific. It's a very cultural item where our ethnic Malays have this cultural belief. They feel that if God gives me this particular disease or this particular issue, and I'm fated to get the disease and die, so be it. So they don't want to come out of it, they take it as such. So this is a major area for us. We need to actually help them to overcome such beliefs and attitudes and move them towards the health promotion path. And so, of course, one of the key areas which we will be working on is addressing these barriers, misconceptions, and also making the screening journey a lot more easier to understand for the local people. And because of a lot of these challenges, education for us and awareness is a major part of our work. And we just don't look at, as I shared earlier, it's not just one screening, we're talking about 4 screening types. We're talking about different age groups, starting all the way from 18 onwards, all the way up. You have the younger cohort, we have the middle age, we have the older cohort. We have the 3 ethnic cultural groups, Chinese, Malay, Indians, plus we have others, like the Filipinos, we have Vietnamese, and a lot of others also in Singapore, if you look at those kind of population. We also have the male and the female, and then we have a lot of other groups, like the working group and those who are at home. So because of this multi-varied kind of setting and target audience, we cannot just take one approach, and we have to actually look at diverse platforms to address different groups at different time points. The key one which we take is what we call as the Gen Pop approach, which is the campaign. We run a lot of traditional campaigns which are thematic. So one year we'll run a campaign on talking about health. Another year we'll be running a campaign which talks about bits, etc. Then we also looked at the screening invitations, which actually person-centric. We moved away from disease-based ones. We have a lot of educational materials, an online portal where they can check their eligibility, make a health appointment, health screening appointment immediately, as well as community outreach. Program performance, as I shared, we haven't been doing that great as far as the screening trends are concerned. We're still about there. And when we look at the follow-up, again, a major issue for us is the loss to follow-up when they go to screening, so put to the hospital. So those with a positive result, we lose close to half the population. 50% of them actually drop off. They don't come back to the SOC or the hospital for scope. And so that's a challenge we have. And of those who actually have been coming up, another 25% drop out even without going to scope. So we have a major challenge here. And despite that, our cancer detection rates are about 1.7, and our adenoma detection rates are close to about 55%. This doesn't take into consideration those who have all lost above here. So probably if you look at that population, our data will look pretty good. Our performance metrics also fare pretty well, not much of an issue here. But moving on to the challenges, I usually put it under 3 Ps. The population factors, the provider factors, and the policy of the program factors. Population factors is what we shared earlier. There is a lot of knowledge, there's a lot of health information, etc. But the problem is addressing the myths and misconceptions and attitudes and beliefs which people have. So how do we look at that? And then key is how do we then increase the participation rates, particularly among the ethnic Malays, as well as our lower income groups, and also how do we improve the compliance or the adherence to post-screening follow-up at our hospitals. From the provider factor, a lot of issues we have is the buy-in from the stakeholders, because there are very many stakeholders involved in this entire program. And we have a lot of issues with the capacity at the assessment centers, particularly for colonoscopy appointments and suites. So that's something which has increased the wait times for our patients. And last but not the least is the cost concerns and gaps in the journey, which we've identified, which we'll be looking at. So when we looked at what we will be focusing on for the next chapter at First Aid Reform, will be how do we change behavior, how do we narrow the gap for follow-up, what are the tools and platforms which can help us with better data sharing, and last but not the least, what are the key levers like? Is it policy? Is it a funding lever? Is it relooking at the way we are actually operating today? So this is something which we will be looking at, and I'll probably be talking about this in tomorrow's session. With that, I thank everyone for the opportunity for sharing, and have a good session as well.
How many things we have here? How many? Got a quick question. Well, I just asked you also because you show there's increasing time between the screening and the colonoscope, and also the screen rate. My opinion is very low. So, do you have any specific studies to use?
Screening rates for women, that's always been a challenge because, as I shared, the women actually have 4 types of screening to go for. So they have to go for chronic disease screening, breast, cervical, colorectal, all 4. And because the breast and cervical programs are much earlier, rolled out much earlier, so we have a good participation in the program for breast and cervical. But what we are looking at is that person-centered screening, where now we're doing a lot of nudges. Tomorrow I'll be talking a bit about what we're looking at. We do have a lot of nudges and notifications and personalized nudges. So we're going to be sending some customized information such that the woman knows that colorectal cancer is also important and to address them is. The second
time, the colonoscope.
Okay, the waiting time for colonoscopy is such a bugbear for us. I think it is contributed because in a way it's a happy problem, you would say. Because when the new initiative, which is healthy age screening, which we rolled out a couple of years back, has brought in almost 2 to 3-fold increase in our screening participation rate. But correspondingly, our centers, our assessment centers, the hospitals didn't have that much time to build up the supply. And so there's always a challenge when we are looking at these numbers. And they have these, what we call as a P1, P2, P3, or priority level cases. So all the emergency cases, the bleedings, the bleeding PRs, and all of these will be the P1, P2s, asymptomatic cases. Our cases will usually fall under P3, P4 because these are the asymptomatic cases. Although they are fit positive, they fall under P3, P4. So these P1, P2s will always be competing with P3, P4, and there's only a finite resource capacity at hospitals. We cannot ask them to say, okay, because my numbers are going up, you give me the slots for these. It cannot be done. So one of the things which Ministry and HPB we are working with, which is also a tug of war with our clusters, is how to increase their rate numbers. So in recent years, within the past couple of years, we brought a few more of the hospitals into our program to increase capacity. We're also looking at whether we can bring in. So far, what we have shared for the program is very much public sector, because the subsidies which the government gives is usually tied to public sector. Okay. So that's another issue.
Okay, because of time, let's thank Dr. Kila. Thank you.